Hello, good afternoon. It is a pleasure for me to present you to Dr. Christopher Rose. Chris is currently a professor in the Department of Medicine at the University of Montreal, and then he pursued several postdoctoral studies with Professor Kettenmann in Germany, Professor Filippo in Valencia, Professor Cordova in Barcelona, and Dr. Itrevo in Norway. Chris was the recipient of 3 prestigious postdoctoral fellowship awards from the Alexander von Humboldt Foundation in Germany, the Canadian Institute of Health Research in Canada, and the European Association for the Study of the Liver here in Europe. Hepatic encephalopathy has been the major focus of Dr. Rose's research for over 25 years. He is currently funded by several public and private institutions. He has published over 77 scientific articles and has received over 60 students at all levels from throughout the world in his laboratory. And he's currently on the editorial board of Journal of Hepatology, Neurochemistry International, and he's in the executive committee member of the International Society for Hepatic Encephalopathy and Nitrogen Metabolism. And without further ado, it's a pleasure for me to introduce you, Chris, and start his presentation.
Thank you very much, Javier. I have to thank Javier and Rafa for this wonderful invitation. It's a huge pleasure and an honor to be here during the liver seminars. It's the end of the day for all of us, but it has been a long day with a lot of different discussions about different topics in liver disease, and including hepatic encephalopathy. So it's been a really rich and fruitful day. So before I start, I have to just mention one of my good friends and my mentor, Juan Cordoba, because when I think of Spain, I think of Juan Cordoba. And it was very rare that I'd come to Spain without traveling to Barcelona to see Juan. And so it's been, I think, it was 5 years this past January. This is the picture from his editorial, which was very beautifully written, and it's a beautiful picture of him there. And just down below, he was, as much as he was a great scientist and a clinical scientist at that, he was a big football fan. So I'm a big football fan too. So I think he'd be happy to know that Barcelona will probably go to the European Championships. So I was given the title hepatic encephalopathy, which is vast, very large. So I decided to take the liberty of deciding what I'm going to talk about within hepatic encephalopathy. And I thought I challenged myself, and I thought I'd take this opportunity to talk about important topics in hepatic encephalopathy. So today we'll talk about ammonia. It's more than just a neurotoxin. Maybe we'll see why. Muscle. Is it our last line of defense against the risk of hepatic encephalopathy? And is hepatic encephalopathy, which is by definition a metabolic disorder, is it reversible? And then, of course, the relationship covert to overt, episodic to recurrent. With this sort of train wreck, are we increasing the fragility of the brain? And the last one, which I think is probably the most difficult, but which needs a lot of further investigation, is the etiological factors and the comorbidities. These different factors can also influence the brain function on top of the liver disease. So the story begins obviously with complications of cirrhosis. Once our liver does not work anymore and becomes cirrhotic, we have an increased risk of having portal hypertension. Obviously our liver is not working properly, so we have liver insufficiency. And I think on this column here is complications of why these patients will actually end up in your clinic. Visceral hemorrhaging, ascites, jaundice, and of course encephalopathy, which is my topic of research, which, as Javier mentioned, has been over 25 years that I've been working in this syndrome. So by definition, when our liver does not work anymore and we have a disease state, it affects the brain, which by definition is a debilitating complication of liver disease characterized by cognitive, psychiatric, and motor disturbances. Another way to put it is that deterioration of brain function due to liver dysfunction, which manifests as a wide spectrum of neurological abnormalities, ranging from subclinical alterations to coma. And of course, this is always the exclusion of other known liver diseases when diagnosing hepatic encephalopathy. So we look at the impact of hepatic encephalopathy on mortality. This study came out of the Danish group in 2010, looking at the different complications. We have ascites, bleeding alone, ascites plus bleeding, and hepatic encephalopathy. And what stood out very clearly is that hepatic encephalopathy has a huge impact on mortality, with 45% after a couple of months, 64% after 1 year, and 85% mortality after 5 years. So again, just showing the impact of this syndrome. A study came out from the Mayo Clinic in 2007, demonstrating if you start grading, stratifying the degrees of hepatic encephalopathy, demonstrating that grade 1, 3, and 2 all had an impact on mortality. Even the one that we actually call now subclinical grade 1 had an impact. So moving forward, which I just mentioned here, grade 1 and minimal has become sort of covert, and the more obvious clinical symptoms, which are defining grade 2 and above, is termed as overt HE. Clinical covert HE, minimal HE is highly underdiagnosed, and for that reason we think there's a lot of patients that are walking around with minimal or covert HE. It's a huge range because of the different tests that you could be using to diagnose covert HE, but eventually 30 to 50% of patients will develop an episode of overt HE over the course of their disease. So again, being in this field for a long time, the advances that have developed in this field are actually enormous over the last 10 years. This was actually one great defining point, is when we first came out with the guidelines for hepatic encephalopathy, which were published in 2014. This is a huge step for the field, to the point where now I think there's been so many changes that it has to be updated, and I think there will be sooner than later. So if you look at the grading of hepatic encephalopathy, the West Haven criteria, which has been out for over 40 years, which in my opinion has done more damage than good for this field. Trying to grade them from 0 to 4, you could look at all the different symptoms, neurological and neuropsychiatric symptoms, which are defined there, which are very arbitrary, very subjective, and therefore it was very difficult to have everyone talk on the same language as far as what we're defining as grade 1 versus grade 2 in the field. So we divided grade 1 and 0 to define covert HE, and 2, 3, and 4 as overt HE. Now it definitely is a continuum. So patients who have covert HE will likely have an episode of overt HE in the near future. And patients that come to the clinic with an overt episode is an episode of overt HE. If they have a second episode within less than 6 months, we call this recurrent hepatic encephalopathy. So if we look at what's going on in the brain, traditionally it's always the astrocytes that are affected. There's an old publication from 1977 demonstrating that Alzheimer type 2 astrocytosis are found in patients that died in hepatic coma. Again, it's the astrocyte that's sort of the morphology has changed. It's rounder. And then we see below from Rajiv Jalan's group, where they demonstrated astrocyte swelling in a model of bile duct ligation. So again, typically it's the astrocytes that we see. We definitely know through many different studies using MRI that there is an increase in water in the brain in patients who have hepatic encephalopathy. Shaw from Germany demonstrated a nice mapping software demonstrating that there was an increase in water. It was difficult to tell whether it was intracellular or extracellular, but we definitely know there's more water in the brains of patients that are suffering from hepatic encephalopathy. So if you look at the relationship between brain volume and ICP, we know that acute liver failure, patients, one of the highest mortalities is due to an increase in intracranial pressure, versus chronic liver disease that we don't see an increase in ICP. And this may be due to the fact that there's less edema in the chronic liver disease versus the acute liver failure. And that way it was defined as low-grade edema. However, this could be challenged because patients who have chronic liver disease are usually generally much older than patients with acute liver failure. And because of brain atrophy and the age onset, there's more space between the outside, the inside of the skull and the brain. Therefore, more water can actually compensate into the brain without getting the increase in intracranial pressure. So in this case, we would have the same amount of brain edema in both, yet we only see the increase in intracranial pressure in the younger patients. Interesting also is that Rita from Barcelona came out showing that HE-related episodes can lead to a further reduction in brain size volume in patients with hepatic encephalopathy. So the pathophysiology, this is a complex slide, and it's a complex for a reason, because it is very difficult to define what exactly is going on. The word encephalopathy is big, and there's probably a lot of different factors that can affect the brain. But we know that if we just look at the middle, ammonia definitely plays an important role. It's involved in astrocyte swelling. And when the astrocytes do swell, it's going to have a miscommunication with its neighboring neuron. And so the communication between these two cells, which leads to proper cellular function, will be impaired. And that could be one of the bases of hepatic encephalopathy. But there's also cytokines, blood-brain barrier leakage, manganese, osmolalite depletion. We know that hyponatremia can induce hepatic encephalopathy. So there's a lot going on in the brain that could lead to neurological dysfunction. So what is ammonia? Per se, it's a weak base, it's a weak acid, in which case at pH of 7.4, most of ammonia is in the gas, 2% of ammonia is in gas form, and most of the ammonia is found in ionic form, 98%. But what makes ammonia so toxic or so special is that its ionic properties of ammonia are very similar to potassium. It has a similar ionic radius, a similar diffusion coefficient. Therefore, wherever potassium goes, the ionic part of ammonia can follow. There's just a picture describing all the different channels. We know that potassium can get into every organ. In that case, ammonia can get into every organ. So what are the first consequences of an increase in ammonia? Well, due to the fact that it can donate a proton and accept a proton, it will have an effect on the pH of the cell. The fact that it's very similar... Hello? The fact that it's very similar to potassium, it can affect the membrane potential of the cell. And ammonia is produced and used in a lot of different reactions within the body. So by increasing ammonia, you'll change the metabolism of many different systems. So because what I just described to you is not very specific to the brain, there's been a lot of newer evidence demonstrating that maybe ammonia is more than just a neurotoxin. Again, ammonia is not just getting in the brain, it's getting to all organs. So there's been a lot of different editorials and a lot of interesting studies that maybe demonstrate that ammonia could be actually acting on other organs. So if we take example, muscle mass loss and sarcopenia and hyperammonemia, we know that malnutrition is highly prevalent in these patients with cirrhotics, and consequently it could lead to a loss of muscle mass and sarcopenia. Interesting, a couple of studies recently came out demonstrating that sarcopenia can predict the onset of minimal hepatic encephalopathy. And the group out of Italy with Riggio demonstrating that sarcopenia is a risk factor for development of HE post-TIPS. We currently just had a retrospective study in collaboration with the group from Edmonton demonstrating that sarcopenia and myosteatosis are associated with development of hepatic encephalopathy. So why is a muscle so important? Well, it has a compensatory role in ammonia detoxification during liver disease. It contains the enzyme glutamine synthetase. Glutamine synthetase amidates glutamate to form glutamine, and in that process removes ammonia. So if you have very good muscle mass, you can actually maybe compensate for this increase of ammonia due to liver disease. So therefore, if your muscle mass is low, which we call quantity, or quality could be just the enzyme itself is not working very well, this will reduce the capacity to detoxify ammonia, which lead to a higher risk of developing hyperammonemia, and therefore a higher risk of developing hepatic encephalopathy. So I just described the impact of muscle mass loss on hyperammonemia and HE, but there's been a lot of recent studies demonstrating that if you look at ammonia per se on muscle cells, myocytes, and so forth, you can see that there's actually a toxic effect of ammonia. So Dazarathi's group from Cleveland has elegantly shown that he's cultured different muscle cells in vitro and looking at the toxic effect of ammonia, and it's through an mTOR signaling pathway that we see an increase in proteostasis. So we've gone ahead recently. We currently use a model of bile duct ligation, which is characterized with a 6-week model. And at the end of this 6 weeks, we see an increase in blood ammonia. We have encephalopathy, which we define by many different behavioral tests, which we have. We have a platform of different neurological phenotype. We have brain edema. And we recently just described that in these animal models, we see a loss of muscle mass at 6 weeks. So we took our model and we treated it with ornithine phenylacetate, which is a compound that can reduce ammonia in these animals. And we gave it from week 0 and treated for the 6 weeks. And then just before sacrificing the animal, we gave a tracer cocktail, phenylalanine and glycine, to try and measure protein synthesis. And we demonstrated that the OP itself had a reduction in ammonia compared to the non-treated BDLs, which led to a decrease in brain edema compared to the non-treated BDLs. But then to our surprise, we saw a rebound effect of lean mass. So here we see a decrease in muscle mass at BDL animals, and then the ones that are treated, we see an attenuation of this muscle mass loss, which we measured by echo MRI. And then if you look at the amount of protein synthesis going on in the muscle, we saw a decrease in the BDL untreated, yet this statistically was removed in the animals that were treated with OP. So this provided us evidence that if we treat the hyperammonemia, we can actually help muscle mass. And then consequently, this patient could probably benefit much better in having a reduced risk of developing HE in the near future. Dazarathi also used a model of PCA and LOLA ornithine aspartate to demonstrate that lowering ammonia also in his animal model can prevent muscle mass loss. So there's a lot of recent evidence in preclinical studies showing that if we can lower ammonia or keep ammonia low, that we can prevent any loss of muscle mass. But what about increasing muscle mass? What if these patients are malnourished, and there probably should be some consulting to these patients to try and do more exercise and so forth to try and maintain muscle mass. But if we increase muscle mass or attenuate it, maybe we can keep ammonia low and prevent hepatic encephalopathy. So in collaboration with a group from Denmark, we had Louise Ammann come to Montreal for 6 months, and she decided to do some resistance training in our animals. This is clinically relevant because she was actually doing a trial in Denmark looking at resistance training in patients. So she took our BDL animals and trained them for 5 days a week for 5 weeks. And she had this protocol where 50, 75, 90%, 90 and 100% of maximal carrying load plus 30 grams. So these animals would climb 8 to 10 times per day, every day for 5 days a week for 5 weeks. So here's just to show you, this is something that it's a cage here, so they're allowed to climb up to the top, rest for 10 seconds, go back down, and they climb up. And they're always climbing because that's their direction. And then you can see the different weights are attached to their tail, so there is some resistance going up. So these results were recently published in Liver International, and we demonstrated that with this exercise training program, that we saw an increase in the gastrocnemic muscle circumference and weight. The weight here, this is circumference. We looked at the hind legs and strength. So we have this measurement to look at muscle strength in these animals. And we saw also a decrease. And then we saw a correlation between the strength and the size of the gastromedial muscle. So this is actually our primary endpoint to see whether exercise can actually help. To our disliking or disappointment, we did not see a change in ammonia. There was quite a bit of variability in these animals, but did not significantly pass significance. So we had to try and explain this. I still think that muscle mass eventually, it could be a question of time with these animals. I mean, we can't go much longer than 6 weeks with these BDL animals. So maybe if they kept on going, it would eventually produce or reduce ammonia, but we didn't see it at this time point in our animal model. So continuing with ammonia, is there a predictive value of ammonia? Now, within the last 3 years, there's a couple of studies that have come out showing that ammonia, here's a publication in 2016, that if you have ammonia of over 1.5 upper limit of normal, that these patients will have a high likelihood of having an episode of overt HE within the next 16 weeks, compared to the other one, compared to under 1.5 and also their controls. So there's a twofold increased risk of having an episode of HE if your ammonia is above 1.5 upper degree of the normal. And then look down below, both studies were done in 178 patients, that if you look at the HE-free, event-free survival, that an ammonia level of over 1.5 upper limit normal leads to a higher mortality rate over 125 days. So this is actually one of the first studies that came out, just showing again that ammonia per se could have some predictive value. Within the same year, a study came out of the US demonstrating, they calculated that a cutoff of 60 micromolar per liter can lead to an increased mortality in over 80 days, 90 days compared to under 60 micromolar per liter. Again, giving us more evidence that this ammonia can have some prognostic value. Acute liver, ACLF, acute on chronic liver failure. There has been some recent studies demonstrating probably some convincing results that maybe ammonia could play a role in multi-organ systems, multi-organ failure. And so maybe we're anxious to see what we'll bring up in the future with ammonia and ACLF. But this interesting article that came out just this month in Hepatology, which is a collaboration between UCL and India, demonstrated on the left, first of all, they were showing that grade 0, 1, grade 2, grade 3, that there was patients with advanced hepatic encephalopathy grade 3, grade 4 had a smaller chance of survival over 28 days. Then on the right-hand side, they cut off the ammonia at 80 micromolars per liter, 79.5 to be precise, and looked at the prognostic value of this cutoff. Here's with all grades of HE, and patients that had over 80 micromolar per liter had a much significant risk of dying. And if you look at grade 1, grade 2, and grade 3, grade 4, again, it was ammonia that actually predicted the mortality compared to the HE per se. I think this is a really interesting paper. It was a retrospective paper, but I think it's something that we should actually move forward with. So this is actually telling us that ammonia, independent of the HE, can have a prognostic value on mortality. So we just talk about management of hyperammonemia. We know that it could be associated with high risk of death, irrespective of the severity of HE. It's quite convincing that ammonia is more than a neurotoxin, and there's a lot of studies demonstrating that it has an impact on muscle mass function and loss, and probably inducing sarcopenia. And maybe ammonia can possibly serve as a general biomarker of outcome for patients with cirrhosis. So with the increasing evidence that ammonia can impinge on different organs outside the brain, it strongly suggests that this metabolic stressor merits to be managed, not only to reduce the risk of HE, but also to prevent any multi-organ failure. I think the problem stands right now is the measurement of ammonia. Not everybody measures ammonia. and B, everyone measures ammonia differently. There's been a lot of discussion. I mean, many pharmaceutical companies want to know what is the toxic concentration of ammonia, and we don't know that. That's why the other study talked about 1.5 upper limit of normal, because everyone has their normal concentrations of ammonia, which would be different from center to center. How are we going to move forward with this? I think someone, maybe me, should really try and standardize the way ammonia should be measured as far as lag time, ice, and so forth. There is an ammonia checker which is available, which is a bedside test, which has been around for many years. It has not moved forward, which I think is a novel idea and a great idea for actually having the benefit of measuring ammonia within 25 seconds as opposed to waiting. Some people wait 2 hours, some people wait 6 hours. So it's a big obstacle. If we want people to measure ammonia, we have to start getting together and finding out what's the best way to measure ammonia. Hepatic encephalopathy, is it irreversible? Textbook stuff will tell us that it's a metabolic disorder. So by definition, you correct the problem, everything should resolve. So back in the day when we were doing transplants, it was a very high risk surgery, and mortality was a very important endpoint. But I think now with a high success rate, 85% after 1 year, 75% after 5 years, transplant is no longer a high risk procedure, of course. So we're shifting to from survival to quality of life for these patients. Are these patients going back to work? Are they living a quality of life? Or are they just staying at home but they're alive? I think due to this sort of shift in outcomes, there's been an array of different articles that have come out demonstrating that there is some of these patients do have these persisting neurological complications that arise or develop after transplant in about 15 to 45% of patients. So if you take many of these studies that looked at these patients that had these persisting neurological complications, looking into their archives, they noticed that these patients had a lot of history of hepatic encephalopathy pre-transplant. I'm not saying it's 5, it could be 1, 2, or 3. And personal communication, but also a publication that came out that these patients who have these repeated, recurrent episodes of HE are very difficult to treat. A study that came out that began in Juan Cordoba's lab, that finished in Janeska's lab, was showing that there is some possibility of neuronal cell loss in animal models that have episodic HE. This was a PCA model, which is a little bit different than ours, but they clearly demonstrated that someone who has this history of HE can lead to neuronal cell loss. Senescence, Professor Heusinger is probably the leader in this department, showing that these astrocytes may stop functioning or may have the incapability of reproliferating. And again, if the astrocytes are not working properly, that's going to lead to neuronal cell function, and it's pretty permanent. Now we know that someone who is diagnosed with covert HE, there's 20-30% chance that that patient will develop his first episode within 1 year, 30%. Once you have one episode, there's a 46% risk of developing your second episode within 1 year. Once you have 2 episodes, within 6 months, there's a 55% risk that you'll develop your third episode. So what are we seeing here? What is this relationship? We obviously see some kind of susceptibility possibly in the brain, becoming more sensitive to these insults, which we didn't see at the first. And so this is actually one of my main domains that we're looking at now in our research centers. What happens when we get all these repeated episodes? This is a really brief. Don't really have the data because I'm not too sure of all the data yet. So we take these BDL animals and we inject ammonia every 4 days. We injected a certain amount of ammonia where they fall into pre-coma, so they cannot right themselves up, or they go into coma. So we inject the ammonia, they fall into pre-coma, and then it's a reversible dose, so they'll come back out. And then we let them rest for 3 days, and then we inject again. So we do this 5 times. So for us, it's 5 episodes of overt HE. And then when we look at the behavior after 6 weeks, we know the behavior of the 6 weeks non-episodic BDL, because that's our model we've well characterized. we see a completely different array of behavioral differences in the animals that had these episodes. Why? That's the question that we're trying to solve now, whether it's something more permanent or something that's going on that we don't know. Maybe it's systemically, there's something different. So that's a big domain which there's a lot of people working on in our lab right now. But then I received a grant for this next hypothesis, which took me a while to win and convince people. But what about hepatic encephalopathy at the time of transplant? Liver transplantation, as we know, it's very invasive. Could take 2 hours, could take 6 hours. We know there's a lot of blood loss, hypotension, degree of anesthesia, and then also the immunosuppressive medication. So I propose that this HE brain is actually a frail brain. So a compromised frail brain becomes predisposed to what would normally be innocuous perioperative insult, resulting in cell injury and cell death. So the classic scenario, someone has HE, don't worry, give them a new liver, everything will be fine. But I think if you send that patient in with some kind of degree of hepatic encephalopathy, he may be frail and maybe be at risk of developing something more permanent due to all these perioperative factors. So we modeled this with our BDL animals. We did a hypotensive model where we removed blood until it went down to 30, 60, and 90 millimeters of mercury for 2 hours. And then after that, we sacrificed the animal and we looked at the neuronal count. We also looked at cerebral blood flow to make sure that what we're dropping in the systemic circulation is also reflecting what's going on in the brain. And we found that with hypotension, we also see a degree of decrease in cerebral blood flow. So then we looked at neuronal cell loss in these animals, and we found that at 30 millimeters of mercury, which is quite invasive, we saw a huge decrease in neuronal cell count. 60, but we didn't see anything at 90. And we did this repeatedly with other markers. One was cell count at the top, and the one in the middle was actually looking at NeuroN, which is a neuronal marker. We just did a lot of Western blots to reflect the amount of neurons in the brain. And we also, to make sure, we looked at cleaved caspase-3, which is part of the cell death receptor pathway, and we noticed that in the animals with BDL at 60 millimeters of mercury, we saw an increase in caspase-3. So then we said, okay, why don't we try and do what we're trying to predict or we're trying to suggest in translational research. So again, we treat these animals with ornithine phenylacetate for the whole 6 weeks, and then we induced hypotension, and we redid the cell count in the end. We know that ammonia goes down. We repeated that value. And then we looked at the effect of OP. So with OP, we've lowered ammonia, which we want. And we did this. This is an example of what we can do as far as behavior. When we put these animals in this open area, and usually if there's a lot of anxiety, they'll stick to the side of the walls. So a sham animal, rats are very exploratory. They'll walk everywhere. Whereas if you have a BDL, usually they'll stick to the sides. And then when we treated with the OP, we saw more exploratory behavior with the animals. So we saw a beneficial effect with the ammonia lowering effect and also phenotypically. And then we looked at neuronal cell count, and we saw we saw no decrease in neuronal cell loss. Again, predicting that maybe there is no neuronal cell death due to the fact that we've lowered ammonia and we've reduced hepatic encephalopathy. So, just before I go on, so again, our suggestions at this point was if someone does have hepatic encephalopathy, we should treat them as much as we can to give them the less risk of having a worse neurological outcome. We weren't criticizing the surgeons at this point because we know that the surgery can go in different directions, but at least if we can treat the patient the best we can, give them the best chance of having the best neurological outcome. So hepatic encephalopathy, I think this is the most important part, which needs a lot of further investigation. We know that the etiological factors of cirrhosis, alcohol, obesity, hepatitis. There's autoimmune, PBC, of course. But these factors definitely can lead to the onset of cirrhosis. And we know that the onset of cirrhosis, which I've just described, can have an impact on the brain. But these factors also can affect the brain independent of the liver disease. Alcohol, we know. You can talk to any hepatologist. Alcohol hepatitis, those patients are difficult to treat. Obesity, where we're standing now with the epidemic of NASH, diabetes, insulin resistance, all these can actually impact the brain. So at one point, is hepatic encephalopathy just due to liver disease and not due to any of these etiological factors? Hepatitis C, which is a great research success story, mostly treatable, but there have been cases where hepatitis C can actually get into the brain. We talk about this brain fog. So it becomes complex, hepatic encephalopathy. And as much as I'd like to keep the story simple, it's not simple. So I think we have to consider these. And I think maybe even in clinical trials, when we try and lump all these patients together, we should try and actually focus on a certain population of patients to see a more pure and cleaner outcome. Of course, age is another factor which we should consider, and which I think we've done a pretty good job with that, because we definitely know that age can have an impact. So how we're modeling this, we have our BDL model, as I mentioned before, which we've well characterized for 6 weeks. So Rafa in my laboratory, as my postdoc, has been working very hard with this model. And at first he gave high-fat diet to a BDL model. For 6 weeks, no gain of weight at all. Bile duct ligation, we're ligating the bile duct, there's no bile, they can't emulsify the fat, so there's no gain in weight. So that was a problem. So what we did, we gave him high-fat diet 3 weeks before ligating the bile duct. So we see an increase in weight in the animals after 3 weeks. We see an increase in weight gain. And then we see an increase in fat mass, just to characterize this model, with an increase in triglycerides and cholesterol. And then at 0, we give the bile duct ligation and we follow them. And the ones that are obese stay obese with cirrhosis. The ones that are not. So we have like kind of lean BDLs versus obese BDLs. As I mentioned before, usually we characterize our model with hepatic encephalopathy behavioral changes here at 6 weeks. But in this case, we've seen changes in behavior at 3 weeks, which we never see in the BDL lean. This is a striking result for us. We're not too sure why. There's a lot to do in this project. Is it because there's more ammonia? Is there myosteatosis? Is there lipid infiltration into the brain? Is there cytokine release? There's a lot of things going on which we have to decide or measure to see what's going on. Why are they developing hepatic encephalopathy earlier than the BDLs non-obese? So if we just take an overall picture of where we're at with hepatic encephalopathy, covert HE, so attention deficits, memory impairment, increased reaction time, sensory abnormalities, difficulty concentrating. And we know patients who have covert HE leads to a poor quality of life. They're incapable of working every day. They're taking a lot of days off of work. And it's associated with a lot more car accidents, so they're a liability on the road. And overt HE is gross disorientation, severe confusion, tremor, hysterexis, stupor, and coma. Signs that are very clinically relevant. Now, I know there's a lot of patients that have covert HE, which can lead to a higher risk of developing overt HE. And once you have overt HE, your prognosis survival decreases. And if you go into liver transplantation, it could lead to a higher risk of poor neurological outcome, and of course persisting cognitive impairment, which can definitely lead to a poor quality of life. So I don't think this is the strategy that we're looking for in patients with cirrhosis as far as analyzing the brain. So where can we intervene? And I think covert HE, as far as testing, is something that we have to establish and move forward with. Testing is difficult. It can be time consuming, but I think there's a lot of new developments in trying to find a test that's actually practical and easy to do and simple to analyze. There's a lot of tests that are out there. Everyone wants to have the test. These ones have been around for quite some time. There's some new ones. The animal naming test has just come out of Italy, which is an interesting test. It just asks you to name as many animals you can in 30 seconds. They have established a cutoff. EEG, I think, is actually very interesting. It's still difficult to place these hats and to analyze the data that we get from these results. But as I mentioned before, I think for us in Canada, the Encephalop Stroop test is probably the best one that we're moving forward with now. So this little test is available on your smartphones. It measures psychomotor speed and cognitive flexibility, and it's been validated against the FEST test, which is a paper pencil test, which has been coined the gold standard. So you begin with Stroop off, measuring your psychomotor speed. You have these different symbols or hashtags, and you got to push the proper color here. There'll be a new symbol with a new color, but this order of colors will change. And then you go to Stroop on, which is measuring cognitive flexibility, response inhibition. You'll see the word green in blue, and you got to push blue, not what you see. And again, these order of colors will change. It takes about 10 to 15 minutes to do. You come out with a score, and what you're supposed to do is establish the norms within every country to see whether you're above or below the norm of your healthy individuals. Jazz is the one who's moved forward with this test. He's done a really good job and has demonstrated that it can predict the development of overt HE within a year. We just established the Canadian norms using 371 healthy individuals compared for age and years of education. And now we're actually moving forward to see whether we can validate what Jazz showed in his publication. I have a huge invested interest in treatments for hepatic encephalopathy. Ammonia-lowering strategies remain the primary goal for treatment of hepatic encephalopathy. And I think you have probably two options if you want to go into this field. You either decrease the production of ammonia, or you try and increase the elimination of ammonia. The slide's a little bit complex, but just demonstrating that ammonia can be metabolized, produced, or removed in different organs. So a lot of treatments target the gut, where a lot of ammonia is produced. So rifaximin, lactulose, probiotics, activated carbon microspheres, polymers, engineered bacteria, and even fecal matter transplantation. These are, again, trying to reduce the production of ammonia. Then you can try and stimulate ureagenesis with ornithine aspartate or ornithine phenylacetate. The strategy here is to try and stimulate urea cycle in the residual hepatocytes, if there are any left. Then you have phenylbutyrate, ornithine phenylacetate, glutaminase inhibitors. Glutaminase is the opposite of glutamine synthetase. So glutaminase is a reaction which forms ammonia. So if we stop that enzyme, maybe we could stop the production of ammonia. Recombinant GS, which is something that's just come forward recently. If you inject recombinant GS, will that allow more ammonia removal? Albumin dialysis, peritoneal dialysis. We know ammonia is water soluble, so it's actually something that's probably very easy to decrease with hemofiltration and so forth. Unfortunately, it's a little bit invasive. Ornithine aspartate, ornithine phenylacetate are targeting the muscle. So glutamine synthetase, which is in the muscle, they're trying to stimulate that enzyme to try and remove more ammonia possible. There could be an issue depending on the muscle mass of that patient. As I said before, if the patient has a lot of muscle mass, he'll probably respond very well to this treatment. Less muscle mass, he'll probably respond, but obviously not as well. Company out of Finland is looking at a GABA receptor antagonist, which they're developing very well. This is actually one of the first neural acting targets, which people have said before, well, if the brain's a problem, why don't you treat the brain? But then the contradictory would be, well, something's coming from the blood that's affecting the brain, so why don't we treat something in the blood? So it's an interesting field right now. Since rifaximin has come forward, there's been a lot more invested interest in this field, and I think the field has actually benefited from it. So what's available now? Rifaximin and lactulose. Rifaximin came out with a study, the results in 2010, so it's almost been 9 years now, demonstrating that rifaximin can prevent the third episode of overt HE, so recurrence of overt HE. So patients were enrolled that had 2 episodes. They ran for 168 days and found that the amount of patients that came back with a third episode, there was a 58% reduction in those patients. There was some of an issue that this rifaximin had to be compared to standard care, which was lactulose. So all rifaximin patients were with lactulose. As I was talking before with Rafa, I mean, in Canada, this indication is limited, I think, the use of rifaximin. I think now in Canada, because we have a healthcare system, patients are reimbursed for rifaximin. Rifaximin can only be given after 2 episodes of overt HE. As I've just described before, these episodes of overt HE can be detrimental. And I think giving this kind of treatment, which I think is probably the best treatment available, after 2 episodes, I think is too late. There's probably a reason why they chose this clinical trial, but I think we should definitely treat sooner than later. And I think that's the problem that rifaximin has right now with this indication. So this is an interesting slide which came out of Barcelona. It wasn't the best study, I have to say. There's some limitations, but I think the message is very interesting. So they took patients that responded and didn't respond to treatment for many different clinical trials that they were involved in. And they found that the patients that were in overt HE for over 48 hours led to a higher mortality compared to patients that were resolved their HE in less than 48 hours. This just talks to you about the urgency of treating these patients. So the patient comes to the hospital and it comes back to this ammonia measurement. I mean, that takes time and you're not sure what to give. Some people thought that you give a treatment to define what the precipitating factor is. But I mean, we're not there yet, but again, this really shows that it's an urgent matter to treat these patients as soon as possible. So my conclusions, ammonia is a major factor in the pathogenesis of hepatic encephalopathy. There's no doubt. It's now beyond the brain, and maybe it's actually causing detrimental problems to other organs outside the brain. Hyperammonemia has prognostic value and merits to be treated. Optimization of muscle mass can reduce the risk of developing hepatic encephalopathy. So proper nutrition, exercise. And I think the brain becomes more sensitized with an increasing number of episodes of hepatic encephalopathy. HE is not always reversible. There's evidence demonstrating that neuronal cell death does occur as a result of these recurrent episodes of overt HE. Treating hepatic encephalopathy, preventing episodes of hepatic encephalopathy will lead to a better neurological outcome, quality of life, following liver transplantation, or even better, avoid liver transplantation. The etiological factors and comorbidities can impact brain function independent of liver disease, and I think this is a big domain of research which has to be investigated further. This actually defines the complexity of hepatic encephalopathy and cirrhotics. And I think covert, overt, recurrent, irreversible is a relationship that should not be ignored. I think this is true. So again, we want to try and decrease the amount of episodes that these patients are experiencing. my last slide talking about the burden of hepatic encephalopathy. It's not just the patient, it goes outside the patient. The impact on the caregiver. Hospitalizations due to HE are very high. Could lead to assisted living, poor quality of life, as I mentioned before. In fact, the impact on the home management, on the family, sleep disturbances, and even driving. So our brain is precious. Happy brain, happy life, living with cirrhosis. I must thank my team back in Montreal, which I have to say it's warmer in Montreal than it is in Spain right now. So everyone thinks I'm in the sun and with the oranges, but I should send them a picture from outside because it's definitely not the case. And so I thank you very much for your attention and accept any questions. Yep, that's correct. I think you don't measure ammonia to diagnose hepatic encephalopathy, that's for sure. But I think we should routinely start measuring ammonia, and there's more evidence that we should maybe treating hyperammonemia independent of hepatic encephalopathy. Because we know there's not always a strong correlation between ammonia and HE. That's always discussed. So to maybe interfere or to solve this problem, I think knowing that ammonia can affect other organs and could impact mortality, I think we should start treating hyperammonemia in general. For my animal studies, no, I don't have any data, but I think it's a great idea. We can definitely let these animals go much longer and let them age as much as we like. It's something that I've been thinking about for a long time, which just haven't done or gone about doing it. But I think it would be definitely worthwhile because, to your point, we know that age has a factor, and whether it's just the natural course of age that leads to sensitive the brain, it could be. But that's a very good point. First of all, I don't think there's one test. I think you should have a battery of tests. It's something I've thought about doing for a long time. Maybe I should establish a battery of tests to diagnose hepatic encephalopathy in animals. We have, again, an array of different tests. Not all of them fail the same tests, and which I think depicts what encephalopathy is like. Encephalopathy is a big word. It's not specific. We have an array of symptoms. So in our lab, we can measure anxiety, activity, short-term memory, long-term memory, rotor rod, motor coordination, and probably a few others which I can't remember right now. So I don't think there's one test. I think you should definitely do a different array of tests. Bajaj from the US has done a lot of work with the microbiota and showing that even rifaximin can change the composition of the microbiota, and that may be one of the reasons why it's beneficial to the parent, to the patients. Whether rifaximin is an ammonia-lowering strategy is a debate. The BAS study, for the indication, ammonia wasn't their primary, wasn't an outcome that they measured. So that's still out there, whether rifaximin is actually lowering ammonia. There's been anecdotal evidence showing that rifaximin does lower ammonia. But again, those patients that were included didn't have hyperammonemia, so it's a totally different trial. So maybe rifaximin was working differently. And even though there was a decrease in risk, there's still 26% of patients that came back with a third episode. So it's not the best drug. There's some room for improvement, if I could say. That's a very good question. I knew that was going to come. Inflammation definitely plays a role to the point where you get infection, you get hepatic encephalopathy. There's thoughts that maybe there's a synergistic effect that infection on top of ammonia can exacerbate the effect of ammonia. So there's no doubt it has a role in the onset of hepatic encephalopathy. What I think is important is the HE due to infection the same as the HE due to hyperammonemia. I think when we get back to these factors that are causing HE, we know that HE is a big cloud of all these symptoms, but maybe if we can reduce it to what's causing HE, we may see more specificity. So right now it's infection that can cause HE, but I didn't lead to that today, but definitely inflammation plays a role. ACLF is driven by inflammation. I know there's a lot of evidence trying to define the entity of ACLF, even for hepatic encephalopathy, that it could be a different entity. And maybe it's something that should, I know there's a lot of investigations going on, and we'll see what comes, but to see whether HE is completely different with ACLF compared to acute decompensation is something to be demonstrated first. As I mentioned before, the different etiological factors, obesity, NASH, alcoholics, hepatitis, they could be different types of patients, which may have a different type of hepatic encephalopathy. So we're trying to lump everyone together, which makes life simpler, but I don't think that's the case. Again, I'm coming back to the alcoholic hepatitis. We know that those patients, chronic alcohol can definitely have an effect on the brain. So does the alcohol shrink the brain and then they become more susceptible to HE due to cirrhosis? I mean, I think that's one of the hypotheses. So to have tools in the future, say, okay, well, are you an alcoholic hepatitis? Then we can have different tools to measure hepatic encephalopathy. I hope, and I think we should definitely do that way. The problem is for hepatic encephalopathy, it could take time to diagnose and evaluate the patient. Whether centers have resources to allow the patient to be evaluated from some expertise, that would be the best, but I don't think everyone has those resources. So the goal is really to try and find some kind of tools or guidelines to help clinicians diagnose HE in a fast, specific way so we can move forward and they could be treated if needed.
Thank you very much, Chris. Thank you very much for coming.